So this is a 68-year-old female patient. As current clinical presentation has stable angina, which is worsening in the past months. Now it's class 3 CCS with a stress positive test for ischemia, scintigraphy with the overall ischemic burden of 21%. As comorbidities, this patient has hypertension, diabetes type 2, which is also already insulin dependent, dyslipidemia. Her body mass index is 33, so she's obese. And she also has a past history of unstable angina in April of 2022, last year. And by that time, she underwent PCI for circumflex and LED with bare metal stents. So it calls the attention. You see the listing of the medications here. It's amazing. She has aspirin, clopidogrel, atorvastatin, and then for hypertension, enalapril, atenolol, diuretics, and then also amlodipine, diltiazem for hypertension, and nitrate. She's taking 3 times a day since the last month. And also on the right, the listing here continues for the diabetic, metformin, dapagliflozin, insulin, 2 types, and also she's taking another medication because she had a breast cancer 3 years ago. Now the lab test, we can see her diabetics is not well controlled, glycate hemoglobin. And in the echo that she did also outside here, it shows a apical akinesia and LV function of 54%. If I may continue here, you see this her EKG at this hospitalization. So there's absent R wave on D3, AVF, and also V2 and V3 with some compromise anteroseptal wall. And now we can see the angio which was performed 2 weeks ago as a diagnostic angiogram. We can already see that there's a stent in the mid circumflex AV branch with restenosis, angiographic restenosis. And in the LED, there are 2 long stents. So these bare metal stents were 2.25 by 32, overlapping with 2.5 by 37 in the LED. So it's total of more than 65 millimeters of stents here. And we can see a subocclusion in multiple points. It appears also a minimal flow distally, but we can see that goes up to the apex.
I think it's total occluded.
It looks like total
in the distal LED.
Maybe some collateral.
There is a correlation with the akinesia in the apex, in the LV.
Yeah,
do you agree with this?
Agree.
Okay.
Agree. In the mid portion, especially.
Okay.
Yeah. Here we can see the LAO cranial view, the same appearance. And I think you're absolutely right. There's some collateral there in the apex. And here we can see in the spider view, again, is not as bad, but we can see also a diffuse restenosis in this circumflex. Here before was a 3.0 by 18 millimeter stent, bare metal stent that was deployed.
When I look at this angel, makes me remind what Roxana Meran described several years ago about the types of restenosis in after you implant bare metal stent. Do you remember that? Proliferative restenosis. Yeah. I think this is a proliferate in the LED.
Yeah.
And almost with a total occlusion in the distal part of the vessel.
Yeah.
So I think it's important to memorize this classification bare metal stent. Yeah. I was not supposed we will still have some places that implant a bare metal stent for.
Yeah, it was type 1, 2, 3, and 4.
Yes.
Type 1 and 2 are focal, multifocal.
Yeah.
And then type 3 was a diffuse, but within the stent.
Yeah.
And the type 4 was total occlusion. So it looks like LED, we might have type 4
diffuse,
and type 3.
Type 3 diffuse proliferative.
Yes.
So the chance of recurrence, it was 80% if you do only balloon.
Considering her clinical symptoms very limited despite the optimal medical treatment and preserve LV function, there was a consideration to try to revascularize all the vessels.
Okay, so suitable. In this patient, there is no option for surgery. We don't need to calculate syntax or syntax score or anything like this because there is no indication for surgery. So in the medical management, only clinical treatment, there is no rule
this patient is taking about 14 kind of medications and is still with class 3 angina. So there is only one option to treat with coronary intervention, percutaneous intervention.
Yes.
So what you have done so far, or what are you thinking how to treat this patient with this diffuse in-stent restenosis? You have the right, you have the circ, so you have a lot of things to say.
We decided to treat the RCA. As you can see here, we tried to recanalize the RCA. It was a little challenging to like an occlusion already in the distal portion, but we were successful. We pre-dilated and we deployed 2 stents, the true sirolium Zeluni stents.
Did you do this case by radial?
We did by femoral.
Femoral.
And we have a stent in the deployed in the mid portion, and then a stent deployed in the distal portion. These were serial stents, and then you can see the distal bed was recovered. And despite the diffuse disease, you can see in the proximal segment, we thought, we should only have more spot stents there to not blind all the RCA, and we are satisfied with this result. So
it was a good preparation to do a hard work in the left system. Yeah. So you did that in a complex lesion in the right. You treat with 2 drug-eluting stents. Do you remember the stent length for both?
Yeah, it was 18 and 20.
In the right.
Yeah.
So the patient came back to treat the left system. So what you were thinking to treat this patient, Ricardo?
So if you can have the angio, this is the first angio we did today. You can see, and I think you're right, it's like an occlusion in the LED, and that's a normal LV function. So we wanted to try, despite very challenging anatomy,
did you see any collaterals?
Just some ipsilateral collaterals coming from the circumflex, but not from the RCA.
So sometimes it's very common when you have a very tight restenosis after a stent, and like we saw, we don't see some collaterals, but the patient has still viable myocardial in the anterior wall and with angina, like we see in this patient, the class 3 angina. So that's a very complex LED.
Yeah,
so what do you do?
We have here a 32 plus 37 millimeter stent.
So are you using a 6 French or 7 French, guys?
We're using a 6 French.
So can you show just the femoral artery, what you did, please? With the camera in the femoral artery, just to see. So
to show here.
You start with guide wire. What kind of guide wire you choose?
Yes, so we're using the EBU 3.5, 6 French.
Okay, the femoral artery, please.
And we went to the left femoral.
Okay.
Okay. We have a selective.
So you avoided to do a puncture in the right because you did it 4 days ago.
Yes.
And now you are treating in the left.
In the
left femoral artery.
Yeah, it was.
So what kind of guide wire you choose?
So the guide wire, the 0.014 inch, we first
was a polymeric or non-polymeric?
Non-polymeric.
Why do you use a non-polymeric?
We thought we could go through the stents, and despite the aspect, having hyperplasia, sometimes
can you show us how did you across this lesion? Did you film? Did you record this?
We did. So here.
Okay,
this is what we try first, and we cannot go.
Is there any specific maneuver to get across for this very long lesion?
Yeah, you should try not to have a very angulated tip, because you're going through a hyperplasia. You have the stents, there is a straight segment. It can slip well better if you go like this.
Let me ask you, Rodolfo. Rodolfo, when you go with a guide wire and an in-stent restenosis, is there a chance to go to out of the wall to get a dissection, although we have a stent there? Could you
if there is a total occlusion, it's possible.
If it's possible. We cannot forget that. It's a very important lesson that Rodolfo is giving to us. Although we have a stent in the artery, sometimes you can go through the struts and get a dissection outside.
Behind the struts, and you can do a dissection in the...
Yes, behind the struts.
Yeah.
Perfectly.
And here, at this point, when we try to force a little bit, it started to go out of the stent. So we have decided to stop here and then to change for a hydrophilic wire.
Why did you change?
Because we cannot advance here anymore.
Okay.
So, and we have a support from a 1.5 millimeter balloon.
So, if you had a chance, would you choose a non-hydrophilic wire?
By first choice, probably.
Okay.
Fausto, look at the tip of the...
Okay. The balloon.
You see.
Yeah.
Yes.
It's coming to out.
Yeah, you see-
Outside,
Okay.
behind the
the
struts.
struts, behind the struts.
I didn't know that what we were doing because I just came, and someone told me,
Yeah.
my spirit maybe told me something like this happened. So, and what
So
you did now?
Here you have to be very careful and just make sure you are in the right place. So next one. Next one.
Next, please.
So
Okay.
here we
So
could-
always when you have the balloon close to the tip of the wire to give you some support and can get
Yes.
across a long lesion like this.
yes,
It's
and
very
then you
important.
just keep
and
advancing
so
to have
carefully.
better support.
Okay.
So see, you can go. We could advance here
Okay.
more to the distal end of the stented segment.
Okay.
next. And here we already changed the view because you want to see the distal bed.
Why did you inject dye contrast in this?
Because here I want to see the distal, the whale tail, and I can
Okay.
see the whale tail
Okay.
there, and that's what I wanted to go. I want to make sure that's not a total occlusion there.
So it
and I
was
am
a
in the
long
right spot.
segment.
It's a long segment.
I agree with you.
And in the cranial view, you cannot appreciate that, how long it is.
That's what's a good choice. So you change the view for the REO because it's much easier to see the artery
Distal
in
part.
the distal
The distal
part.
part of the
From the
Yeah.
apex.
And our
from the
target
yes.
was to go to the whale tail there, one of the branches there. Next.
Okay, can you go again, please? Next. Next. Oh, great.
So now
I like that.
we are there, and then we could,
Inflate the balloon.
yeah, we went first with a 1.5 balloon.
What? 1.5 balloon.
1.5.
Okay.
Because a very, very small distal vessel
Uh-huh.
at this point. We want to make sure that we're not causing any injury
Okay.
here, not dissecting, not perforating. And we went through the whole stented segment.
So
and
it's
this-
1.5 by 12 or by 18?
by 20.
By 20.
By 20.
Okay.
And at this point, we could recover the anterograde flow despite the distal bed. And now we are ready to do something very important, which was to go with the intravascular imaging, in this case,
Look at the
IVUS,
distal.
to try to see the mechanisms involved in this
Okay.
restenosis.
Okay. So you did already did the IVUS?
The-
We did IVUS.
The wire is not in the true in distal
Yeah.
part yet.
Yeah, we did
Yeah.
what we did, Fausto. We reached the distal part and we tried to what we
just
did
go-
was
yeah.
exchange
Okay.
the guide wires here.
Okay.
Here,
So
Fausto,
that's
here we
here.
can see.
Okay. Okay.
Videos.
Yeah, here's
so-
the whale tail.
Okay. So you did do the other direction now.
Yes,
Yeah.
the other direction, and then there, yes, parallel
Oh, and
guide
at this
wires.
point, very
So what
important,
kind of guide wire you choose?
Yeah,
The
because-
first one you use it or not, we use the third one?
we have a hydrophil. First, we with a BMW, so it's already open.
Uh-huh.
It didn't go through. Then we went with a pilot.
Okay.
And we went through. So we didn't want to keep working because the tip of this wire, you're very distal, you can cause perforation.
Yes.
Wire
So
perforation.
You change again for the first
We
one.
went back with the first wire.
Great.
And it went
Correct.
very
So
easily.
this is another important lesson to avoid a complication in a case like this. He started with a BMW. So, and after he could not cross, he moved to a pilot one, and he could cross. And to avoid the perforation in the distal part of the artery, he came back with a BMW. It's a very important teaching in this point. So now,
And then we did we after the predilatation, we did the IVUS.
so you have the image.
We have. So here we started distal to the stent, the very distal LED.
Okay.
You can see it's about 2.0 vessel. You already see some diffuse here. This is a stented, the distal edge of the stent is about 2.0, I would say 2.1 by IVUS. Remember, IVUS tends to overestimate by 10%. And we start to see the hyperplasia here, not compromising very much the vessel, the lumen vessel.
Do you think the stent is well expanded?
Yeah, here we're going to start to see some spots. I think it's a little bit undersized. The vessel is larger, it's about 2.5, 2.7 at this point, but it's a lot of plaque burden, of course. And there's some spots here of underexpansion compared to the more distal portion. Now, as we move more towards the mid portion of the stented segment, we see diffusely a presence of hyperplasia here. And this is after post-dilatation, but it's better expanded at this point. And we're going to see that this distribution of hyperplasia sometimes is more concentric, sometimes more eccentric. We don't see signs of funny things like macrophages and things that we see nicely by OCT. So it appears to be a regular hyperplasia. Now the vessel gets larger, is about close to 3.0, but the lumen is about 2.5. So I think the stent at this point is a little bit undersized and a lot of hyperplasia diffused hyperplasia. And here we can see how undersized to the EEM it is. It might chance to have some positive remodeling as well. There's some calcified spots here, more underexpanded. But I wouldn't say, Fausto, that the main mechanism here is underexpansion.
hyperplasia.
I think it's intimal hyperplasia with the barometric stent in the insulin-dependent diabetic.
And how do you think the underexpansion can play a role in this case? Just no?
Yeah, I think it can. There's the spots of the underexpansion sometimes is where you see the minimum lumen area, but as I mentioned, I think that's not the main mechanism for this proliferative restenosis.
So as a recommendation for in-stent restenosis, we need to use IVUS to identify the mechanism of the problem. So the mechanism here is predominantly intimal hyperplasia.
Exactly.
Do you agree with this?
I agree with this.
So,
and that's important information.
So you have a long segment with stent, a long segment with in-stent restenosis. What is your decision now?
In this type of restenosis, if you use a regular balloon, even though you can achieve a good result acutely, the chance of restenosis can go like 60, 70, 80% because a very long vessel and very small vessel as well.
Next option, drug-eluting stents.
If I go with drug-eluting stent, there are some studies comparing a drug-eluting stent and a drug-coated balloon. You can have a better result in terms of late loss with the drug-eluting stents. However, very long segment, a double layer of stents. This patient already did not responded well to stents, and you have a very caged vessel that we don't think that's a best option as well. If you can avoid that with some other option that avoid to put more metal, we think is better. So what we did here, let me just advance here. Drug-eluting balloon is just a delivery of the drug, so we have to achieve a good result with balloon angioplasty.
Mm-hmm.
And we went first with a non-compliant 2.0 by 20 millimeters.
Okay.
And we went
so we start, just for the audience, we start with a 1.5. You did a preparation for IVUS. You did IVUS. You bring a 2.0 balloon. Could you bring a 2.5, or do you think the vessel was too small distal?
The very distal 2.5 will be too much.
Okay,
so we went to 2.0.
We cannot oversize the balloon in a case like this, mainly because of the distal part of the artery.
Yeah.
Okay, you choose a 2.0 balloon,
2.0
non-compliant
by 20.
by 20.
Because non-compliant, you go to high pressure, you can also
You need high
better
pressure.
expansion.
Okay.
Better expansion.
What kind of, how much pressure did you use?
25.
25, yes.
25.
Can you see the results?
Here distal, here more
Yes.
proximal, and then here we went with a 2.5 by
Okay,
20.
can you go back just to see after 2.0?
Because
Okay,
the
you
end-
still don't have distal flow.
No.
Okay.
Yeah.
But the arteries looks better, but not as good
Still very
as
small.
we could
It's
expect.
some spasm.
Okay, spasms, some spasms. Okay, so you
here-
brought a 2.5 balloon.
Yeah,
now.
here is clear that in the mid portion is not good result for,
Yes.
for balloon here.
Uh-huh.
So we went with a 2.5 by
2.5
20.
balloon.
Again, high pressure,
Okay,
even higher in the proximal segment.
okay.
And we want to prepare throughout the entire stented segment. And here is the control angel that we have.
Let's see. Okay, wow, distal.
It looks like within the stented segment a very acceptable result. And
So you still have a total occlusion in the distal part. We cannot see the distal flow.
It's not occlusion.
we
not
think we
total-
have flow, but it's very spastic still there.
Okay, so what's your next?
So the plan now, we think it's good enough to go with the drug-coated balloon. So we have today the Pantera Lux is a paclitaxel-coated balloon. So here we
Let's
want to
see.
position exactly at the distal edge of the stent.
Mm-hmm.
And now it's very important. We don't want to achieve an optimal balloon expansion. We want to deliver the drug.
Now you see the hemodynamics. The blood pressure is 120. No problem. The heart rate is okay. It's about 77, and we have balloon for more than 1 minute. For how long?
So 1 minute and 30 seconds. So this is more than enough. And of course, there's still some hyperplasia there, but the lumen is very well recovered after this pre-dilatation. Wagner, coloca view grande, por favor. Pre-dilatation and the drug-coated balloon. So Fausto, I think it's a much better expansion. I think that's very clear.
Yes. It's
Closer
clear.
to the external elastic membrane. And this is very typical imaging when you do IVUS after balloon angioplasty and drug-coated balloon. You're still going to see hyperplasia. Sometimes you see some micro dissections there within the hyperplastic tissue. But this is considered acceptable if you have a good luminal area after your treatment.